A little way of introduction. My name is Ashley Fischer, and I am a pediatrician by trade. So I grew up very locally. I went to IBC over in Chillicothe. I did my med school here in town in Peoria. I did my residency at OSF, and then I practiced in Pekin, Illinois, outpatient pediatrics for 10 years. And so my interest in LGBTQ healthcare, I'm one of the rare stories that I don't actually have a personal connection to it. And a lot of people ask about that and then are a little surprised on that. I've always been an advocate. I was in allyship groups in college, have a lot of friends that are part of the community. And then my senior year of residency, we had had no education on LGBTQ healthcare. And I was like, this is something we need to have. Can I arrange for just a 1 hour educational conference? We have one every day. I was like, can we do one on this? And they're like, yeah, go for it. And afterwards, I had, probably like 60 people reach out to me because no one had ever done that before. And there was no access here. They were literally like, there's nowhere here in central Illinois that we feel safe to get medical care. Like, can you do something? Can you help us? Can you do this? And I'm one of those people that sees the voids like that, and I just can't not fix the problem. And so I advocated for many years, many red tape. So 5 or 6 years it took to finally get a clinic started. And we do have a clinic now downtown, Positive Health Solutions. So this started as an HIV federally funded clinic. So they treat patients with HIV. And then about 8 years ago, because of a lot of the crossover with the gender-affirming community and the lack of access here locally, they started doing gender-affirming care as well as primary care for the community. And then 2 years ago, I got added, and now we do pediatric gender-affirming care there as well. And so my education, like I said, general pediatrician by trade. I have done multiple different courses in gender-affirming care through WPATH. So I've done their foundations course. I'm currently on track for certification. It's a 2-year process. On that, I go to the WPATH conference every single year. And we have 3 pediatric endocrinologists that we use as references if need be, and as well as a really good working relationship with both Rush's program and Lurie's program. And that's who we modeled our clinic after. So that's the medical side of my story. And then the advocacy side of my story, you already heard some of it, that the need in the community, and the more I saw that need, the more I felt we really needed to fight for it. And so my more popular advocacy stories, I ran for school board earlier this year. So I did that in Morton, Illinois. One of the biggest reasons being there's a really big bullying issue there, especially with the minority communities. And to the point that there was a French teacher that literally said gay kids are not wanted in the womb. That's why they're gay, like in the middle of class. And she was not fired. And so things like that. I ran for school board, and because of my advocacy for the LGBTQ community and my medical work with them, it was crazy. I was in the news across the state. I was getting phone calls from people in Springfield, people in Chicago. I had death threats. We had to send my children away for a weekend while we figured the FBI got involved, and the police were like going by my house every, couple hours to check on it. It was one of the craziest experiences I've had, but I learned a lot through it. So I now know a lot about our political system. I know a lot about how those things work and where you can make differences and where you can't make differences. So I'm also really happy to answer questions about that. So I have a lot of things I could talk about, but I was going to open it up just for questions to begin with anyway, because it tends to guide conversation after.
I'm going to start with a question,
yes.
And I think it's something that a lot of parents kind of want to know. When they put a youth on hormone blockers because they are questioning or they think they might be trans, can you talk about what those blockers might be? Are they long-term? Can they change their mind later? Do they harm the body at all?
Perfect. So my favorite thing to talk about is what I don't do, because that is like half of, I feel like, the defenses I have to make these days, is because the media has really skewed a lot of these things with just false information. So basically what a puberty blocker is, so we have been using these medications for decades, like 40 to 50 years. And we use them for what's called precocious puberty, which is where a 6-year-old starts puberty. So like they start having their period. And the reason we have to stop this is because A, when you go through puberty, you stop growing. your growth plates stop. So you're going to be the height of a 6-year-old the rest of your life if we don't stop it. The other is that your body's still growing and developing, including your brain. And those hormones play a huge part in your maturity and your social development. So if you think about talking to a 12-year-old who's like still thinks farts are funny, and you talk to a 16-year-old, those are very different maturity levels. And that is because of the presence of sex steroids. So estrogen or testosterone, we all have both. Not everyone realizes that. We all have both at different varying degrees, are what help mature the brain in that way. So if we allow that to happen at age 6, I'll be honest, I don't 100% know what happens because we've ethically never done that. We've never just been like, let's see what happens to this kid. And so what we do is we pause it. And so the pathway of puberty is much more complicated than I probably would have made it if I was the great creator. But there's a signal that goes from one part of your brain to another part of your brain that then makes a signal that goes to your gonads. So like your testes or your ovaries. So where the puberty blocker works is the first signal. And basically what it does is just locks into the receptor that never lets it send the signal to start puberty. And it just chills there. And when you stop getting it, so it's typically a shot every 3 months is the most common one. When you stop it, it pops off that receptor. And if the time is appropriate, like your body was like, yeah, it's time for puberty, you will go through puberty. So it will send the signal, it will go to where it needs to be, and puberty starts when you stop that. So there is no cases of like permanently never going through puberty. That's just not how it works. And so, in these precocious puberty kids, we wait till an appropriate age, usually like 11 is when we recommend it, and then they stop taking it. And then they go through puberty at that appropriate age that allows their body to develop. And so they're safe medications. The only, I would say, like downsides to them, so there are 2, one being fertility. And so we don't have a ton of information. Like I wish I could give people a number, and I say this all the time. I wish I could be like, you have a 40% chance of infertility. You have a blah, but we just don't have it. And the reason being, as much as the media tries to make it seem like we're treating hundreds of thousands of kids, we aren't. And so the numbers just aren't there. We have to have enough numbers of kids that went through blockers, hormones, are now adults and want to have children that we have tracked to statistically get those numbers. And we just don't do it to that size. So I can't yet. We will someday have that data. So I can't 100% give like a good estimate on that. What I can say is it does decrease your fertility, but it isn't 0. So I always say like it's not 0. There are plenty of cases, anecdotal cases of kids, transgender kids that went through blockers, went through hormones, and went on to have their own biological children. We do take steps to try to mitigate that. So we do not stop blockers or start blockers until you have biologically gone through at least the first stage of puberty, which allows your gametes to mature. So you have mature sex gametes, and that is when we start the blocker, so that we have a much better chance at someday, if we needed them, to use those cells. That was like a lot of like, I know, medical jumbo. Does that kind of make sense? So, nope. So they, right now, yes. So shots is the most common. They make a 3-month one. They make a 6-month one. Most insurances in Illinois will cover the 3-month one. It's harder to get the 6-month one covered. They also have an implant. So this looks a lot like Nexplanon. And so it's like a little rod that goes in your arm. And this usually is good for about 18 months. And so then you only need it that one time. A good question though. The only other thing we have to look at is bone density. So your bone density does go down a little bit, which is basically how strong your bones are when you're on this, but it's never been clinically significant. So what that means is like, yes, the number goes down, but no one has more breaks. I anticipate someday we won't even be checking, but for right now, you do still have to check that yearly when you're on it. So there's honestly very little downside. I say that all the time. Like the side effects are injection site reactions. Like kids don't like shots, and I don't blame them. So it sucks to have a shot. But the fertility and the decreased bone density is it. That's really like the only downsides to it. It's not going to make it to where, eventually you need to, you won't have puberty, or there will be permanent mental effects or anything like that. Because like I said, we've been using this for decades on other kids. I'm looking at this picture. I probably should have brought my slides because they are like pretty good slides. But there is a good picture study out there where I like to show why these can be so important. So when we have, a lot of these kids that knew from a very young age. So I say like, it's pretty normal and common for people, for kids to know pretty early on. So 3 to 4 is the most common for me. And they knew pretty early on. And when you have ones that are that committed, that confident in it, that's going to be their lived existence. And we can make that lived existence much easier for them with things like the puberty blockers. And I'm going to, if I find it, show you this picture that shows you twins. So these are twins born natally male, both of them. One is transgender, one is not. One went on, one went on blockers, and one obviously did not. Oh, stop it. And the amount of surgeries that child's going to require at a later date and time to present as female are minimalized extremely. So you'll see where her brother has a very, there we go. Her brother has a very pronounced jawline. He has an Adam's apple. He would not safely be able to pass in a society that makes it dangerous for them to be not 100% passing. And so, the amount of surgery, she will be safe. She will not have to have her chin shaved, her cheekbones shaved, anything like that, because we never allowed those changes to take place. The difference in appearance is significant.
Are they identical twins?
Mm-hmm.
Wow.
So that's one of the big advantages. The other is the mental health aspects. So for those of you that did not know, that's the biggest reason we treat. So I tell parents all the time, like, why do we treat? Is it just because 11-year-olds tell us they want it and we're like, oh, okay, we're just going to do what you want, I suppose? No. But so we treat, like, from a medical perspective. They've done a lot of studies on this. Even just 10 years ago, I would tell you that I have 6 or 7 really good studies that show mental health benefits to hormone treatment. I now have over 26. And the reason being, just so many of them have come out over the last couple of years, because they take like 10 years to do these studies. And the reason they even started studying it is because a really big survey, done in 09, and it was across Canada, America, looking at, I'm going to not remember the number now. It was like 26,000, showed that 42% of pediatric, so like adolescent transgender kids, had tried to commit suicide in the past year. Not like had thoughts, not had a rough time, actively tried to. 10% of them had tried 4 or more times in the past year. And so this is one of the greatest comorbidities we have. I tell doctors, I do a lot of educational lectures for the medical community. And I always say, this is like a higher rate than actual depression. This is a higher rate than cancer kids. This is the highest rate of suicide attempts that we have. And so that's why we want to treat it. And like I said, I brought a lot of resources if anyone's interested, like they're ones that I hand out in the clinic. One of them is a list of all the studies. So it is 11 pages long, because that's how much data we have now. And conclusively, every single one of them shows not only improvement, but a vast majority actually show a return to cisgender levels. So once they are on treatment, once they're going through treatment, they come back down to that level. The other misconceptions I get about treatment a lot is that we go really fast, or that we make these irreversible changes really fast. And that's also just not true. And so when we do these hormones, so the example I like to give best, because I think it's a good way to conceptualize dosing, is estrogen. So when we start estrogen on a 13, 14-year-old, that's the earliest we'll do it, is a good puberty time. And we do have requirements, by the way. There are very set guidelines for who gets treatment. We're just not willy-nilly, you get treatment, you get treatment. And one of the big ones is they have to have lived in that persistence for at least 6 months. So it has to have been either a social transition, or it has been where they're seeing therapists and it's really a thing that's affecting their life. We're not just handing this out to anybody that wants it. And the first visit I have is an hour and a half long. That's how long it takes me to do informed consent, to talk about everything. And the informed consent they sign is 6 pages long. So it's not a small thing. We do explain all these things ahead of time, and just doesn't go to anyone. Anyway, the point being, when we start, we're imitating puberty. I always say that. Our goal here is to imitate puberty, just the other one. And so nobody wakes up with boobs one day. Nobody's oh, there they are. I have a beard all of a sudden. That just isn't reasonable. And so our dosing changes are every 4 to 6 months, the same that would occur in a natal puberty for your body. And the first dose we start at is the equivalent of 2 birth control pills. So if you're okay having your kid on birth control, this is minimally higher than that. And that's what I said, not even 2, it's 1 1/3 or 1 2/3. And so I think that helps people kind of conceptualize that we're not doing crazy high doses on this. And then we go up, like I said, every 6 to 4 months. And that helps so that those changes that are happening are happening slowly so that they can kind of figure out if it's helping, hurting, if it's what they like or not like. And it also prevents it from being like 100% permanent if that becomes something they don't want. The only things I talk about with the hormones that are permanent, so like stuff that if you went off of the hormones, you would go back. So like it wouldn't go back to your natal state. In general, I say if you're changing tissue or you're growing tissue, that's not going to go back. So if you grow boobs, they don't fall off just because you stop taking your estrogen. But that's about it for estrogen. That's one of the only ones that does not go back natally, is over time, your body composition and everything will go back. Testosterone, voice is the big one. So if you grow an Adam's apple, that's just a thickening of the cartilage in the front. Can you go in there and surgically shave it down? Yes. Is it a horrible surgery? And I don't recommend it. Yes, but it is possible. So it's irreversible in the sense of the hormones will not change that. But there are surgeries you could do to change that. Anything that happens like swelling of the genitalia, which I always tell parents is not going to be like phallic. Like you have to go way out of your way to try to get like phallus out of the genitalia. If anything, I actually think most people tell me sensitivity goes up on hormones. And so I actually have a couple that it's a bit of an issue where they need to wear like looser clothes and stuff. And so it doesn't affect things like the sexuality or anything like that. If you grow a beard, then that is also permanent. This takes years. I always try to tell people though, this takes a really long time. You have to like change the follicle. And so by the time you get there, like you're committed to one road or another. So once again, the permanency of things, like I'm not gonna say we don't talk extensively about it, we do, but the permanency that I think a lot of people make so significant in the media is just not there to the extent they try to make it. Like I'm not gonna say that 5 years down the road, yeah, your breast tissue is gonna be like there, which you can once again surgically remove, because it would be, but it's definitely not 13-year-olds running around with double Ds. Like that's just not happening. So that was, again, a lot of info. Yes. To get rid of breast tissue? If you are natally male and you go on estrogen and breast tissue grows, if you go off of it, that will decrease slightly in size, but you've made tissue. So it's not just going to fall off. So that like the ductal tissue that is under the soft tissue swelling of breasts is going to still be there. It's breast tissue, yeah. So it does. That is another one that, like I said, takes a while. So the beard and the breast tissue does take quite some time, and it's because like your body. I mean, it takes time in natal females. Like if you think about like 12-year-olds, like they don't have actual breasts for like a year and a half because it takes that long for that ductal tissue. Like it's mostly just soft tissue kind of coning, and that's what you're going to see a lot in the beginning. And then over time, then it will turn into that ductal tissue. It's still with hormones, like it's going to be really hard to get anything above like a B cup. Like you're still not going to be able to change things to the point that like you're going to have Dolly Parton size, like prosthetics can do that. And I will say prosthetics have come a long way. And I do talk about that a lot with my teens where, so many of them want to look like their peers right away. And I get that, like their friends have breasts, and so, but prosthetics have really come a long way from stuffing socks on your shirt. Like they are silicone, they mesh into your skin. They have sets that you can do that increase in size. So it looks natural. Like you don't just show up one day with like, B cups. And those can be really good at affirming. I do always, at the beginning of my talk with parents, I emphasize that gender affirming care is an umbrella term. Okay. There's lots of things under that. And so with the kids, I like to say, it's like saying I have a dog. Do you have any idea what my dog looks like? No, there's so many different, breeds underneath that. And so gender affirming care is an umbrella term. And this can be using their preferred name. This can be letting them cut their hair how they want. This can be doing binding or tucking or prosthetics. This can be, medications on that end. I'm not going to say they don't play a part when they're necessary, but they're not going to be the first line, and they're definitely not going to be needed or the right thing for everybody. And there are so many other things we can do to still have that mental health benefit and to still support them that don't have to do with medications. So another really good study actually showed that your chance of suicide and depression goes down by 25% for every single place you can use your preferred pronouns and name it. So if it's school, that's down by 25%. If it's school and home, that's down by 50%. If it's school, home, and church, that's down by 75%, kind of in an additive way. And so I don't belittle with parents. I say the most important thing we can do, like my part is, is minimal compared to the positive benefits that a supportive home environment can have. And it doesn't have to be, there's another slide I have where I say it's not as complicated as everyone thinks it is. I think because we give so much weight to this particular topic, just because of everything going on in media and in our, social, like our social structure right now, that it feels heavier. But I tell parents, you're already doing all these things, like the right stuff, in other instances. So the example I give is if we have like a 6 or 7-year-old, and one of the first things I ask them at visits, I'm like, what do you want to be when you grow up? And like none of them are like an accountant, like that's not right. Like they're like, I want to be a Cubs baseball player. So this is fantasy play. And what do we say back? Like we don't bring them back down to earth. We're not like, no, like 0.1% make it. This is a ridiculous dream. You need to drop it. Let's talk about some like better opportunities here. You do, you're like, that's amazing. Do you like baseball? Like, that's so cool. Like, are you, and you do the exact same thing. And so I think that just because we give gender, like I said, this unnecessary weight in the context of everything, that it makes it seem like it's bigger or it's harder or it's more complicated than it is. And so if that 7-year-old tells you like, I want to wear dresses, it's, oh, okay, why do you want to wear dresses? You just think you're comfortable? Okay, let's go get some dresses. Like, and it doesn't have to be a big thing. I want you to call me this now instead. Okay, how'd you come up with that name? That's kind of cool one. And if they switch back, cool beans. I like that name too. We'll go back to that. And it doesn't need to be, that support is where you can get the most benefit mental health wise. If I had to pick, that's always the one I'd pick. If it was like I had my choices between social transition, medical, intervention, even like therapy, mental health, I will always choose a supportive home environment over the others.
I was just wondering if putting your child on the hormone blockers and then estrogen hormone, if that will see any noticeable.
So it's not necessarily decrease. There is atrophy over time, and I'm going to say like years. There are things you can do to counteract that. So if it does become something that the patient like wants to be able to function with or wants to have use of, you can do testosterone gels on the site. And so you can do like there are different apparatuses.
I don't want to promote it. I want to unpromote it.
Yeah, and that's why, like I said, I do find that regardless of which hormone, because we're kind of thrown into puberty, there's always a libido burst. So there's always going to be like a little bit of a libido burst there. With estrogen, the biggest issues are that patients complain of to me is just functionality. So like difficulty sustaining erection or difficulty with ejaculation, some things like that. And that's where if like their sex life is an important part and it's something, and I'll be honest, for the most part, I very rarely have this conversation, whether they're too embarrassed to because of their parents or they're just not quite at that age yet where they're like super worried about it. And like I said, the doses we're on are not going to be so significant that like they're going to have huge effects in that area either. But there are things we can do to like counteract those sexual side effects. So it does not shrivel up like a bean. Like so the atrophy is, like I said, going to be over decades, and like we will have talked about interventions if that's the case. And not everyone needs a high enough dose to have like those issues. So especially in today's day and age, I would say like half my patients are kind of in this like non-binary category, which is where they want either just like a more feminine appearing masculine or the opposite, where they don't necessarily want like breast tissue or a beard. Like that's not important to them. Ambiguity, like a little bit, and looking just like slightly more feminine or slightly more masculine is important to them. And that can actually be accomplished with pretty low doses that don't have a lot of like the physical risks that would come with the higher doses for full feminization. Does that answer your question?
Yeah, I guess. I think I need to go on Amazon and like do some books and stuff. I'm trying to like decrease the occurrence of stuff down there.
Yeah.
And so I just wasn't sure once we put my daughter on estrogen that would help with that.
It can. I will find, like I actually brought a handout on tucking. And how to safely do it. I do find that most patients find that to be the most satisfactory because
we have in the wardrobe.
We do.
Yeah.
So, which is basically fancy Spanx. Think of it as fancy Spanx.
Yeah.
So it's Spanx that just tuck it all back and up.
Do the tuck for you.
Mm-hmm.
We have some junior sizes in there that are for kids, so that you don't have to worry about them being too harsh or too restrictive. But they will do that for you. So if you want to go get one for free
Okay.
and play with it, well,
And they don't, I find, like I said, like, you know, gender affirming care, like under that umbrella, there's so many different ways to do that. And if like appearance of genitalia is really important, and it's not to everybody, that's pretty effective at tucking it away and out of sight and out of feeling it all the time. It can be slightly uncomfortable. So the gaps are the most popular, which, like I said, most just basically spanks. Like they're just, but you can do taping, like if that's not super comfortable. And this handout, you guys feel free. I have so many things over here. Talks about how to safely do it. It has videos on there that they can watch, different things like that.
Yeah. Yeah. That's right. Yeah.
Yeah.
Okay, yeah.
You're here. Oh, you can ask. Oh, I always preface that too. You can't say anything insulting. Everybody, yeah. No, it's okay. Yeah. Everybody is learning. Everybody's at a different part. And that's why I say there's nothing you can say that is going to insult me or anyone here.
Actually, but none of you are in. So
no.
Yeah.
feel free, your privacy is
Privacy
safe.
is the top priority here, and you can talk about whatever you need to talk about, and we're all here to do that.
I'm saying stuff like that. Really.
Yeah. And so honestly, I would tell people like a lot of what I do at my clinic, I would say probably like 30% of the time, I do not prescribe medications. So it is just a lot of like talking about the research, talking about the options, and then like talking about these other options that can also happen. And just, it is a pretty extensive world to all of a sudden get thrown into, and trying to like know all the different parts of it. And so I do find that like having people that know already can be very useful. And so I do emphasize, like, you do not have to be just looking for medicine to come see us. Like if you just want more information on that, especially for your child, if your child wants more information on that. So I always say they're part of that informed process, you know, and I do not know many 11-year-olds that can Google that good, that like, you know, can find this all out. And a lot of times, like, I will surprise them with like some of the options that are there. And so don't feel like, because it's a lot, you know. And another thing I always tell parents too is we have a lot of parent support groups online, and I'll like flat out bring this up in front of the kids sometimes, because I definitely do have some that come in that are just so much animosity because the kid's so sure who they are, and they're just like so angry the parent just won't like 100% right off the bat accept it. And we have to really step back and talk about, like, it's not that they don't want to accept it. There is a grief that comes with this. There is like a loss of a future they had planned out, of a future they had seen. And it's not that it's worse, it's different. Like, it's something you have to adjust to, you know. Like, I do the same talk when we get an autism diagnosis. I say, it's not bad, it's different. It's just different, but there is a grief of that path that, you know, is no longer what you see. And that's okay too. And that's why I say there are a lot of really good parent support groups for that, where you can kind of have those discussions and not worry about, you know, your kid overhearing it or anything like that. So.
Yeah.
Mm-hmm. It is, you know, and they chose that name while you were inside of them, and you know, they dreamed of first dances and stuff like that, and like kids for the most part, I mean, they're pretty selfish that age, let's be honest, but they at least like they get it to an extent. And I think sometimes trying to have like a looking at both sides. So for instance, a conversation I have the other way is they did this really good study that looked at, it's not this, but it's anxiety in pediatrics and how the treatments we use for them, which are SSRIs, how effective they are. And what I found most interesting from the study is there was a 27% placebo effect. That means 27% of kids who got a sugar pill significantly saw their anxiety go away. And so sometimes it is the act of doing something that really can like play a part in that mental health. And so when I have really hesitant parents and that kid that is just like so gung-ho and angry about it, we'll compromise. And I'll be like if we start at half a pill, there will be nothing permanent from that, nothing, you know, and you'll take a slight risk with some of these other things, but nothing that would really get in the way. But it's just the act of saying like, okay, we hear you, we're going to like move forward with this and give you this can be pretty significant too. And so it's sometimes like kind of seeing, like I said, both sides of trying to find that compromise.
Just to kind of backtrack, when we talk about acceptance and that, this combats a lot of the misinformation out there. You know, I'm sure we've all probably seen it. You know, when my kid was 6, they wanted to be a dinosaur kind of thing. meaning that they're going to change their mind at some point for a lot of it. But what would you say is the percentage of people that you deal with?
Very good. I can give you statistics. I don't even have to give you what I deal with. I would say that the absolute lowest of persistence percentage would be 92%. And the reason being that was based off of a very extensive study done in the United States. So once again, around 26,000 people that showed 8% had detransitioned at some point. Of that 8%, half of them only detransitioned due to social reasons, financial reasons. They did not want to detransition. The other 2% had only detransitioned to a non-binary. So they went from transgender to non-binary, which really leaves you less than 2% that truly detransitioned. If you're going to look at other countries, so one of the ones I find most interesting is Sweden, because Sweden has allowed you to change your legal marker for gender since like the 40s. I mean, like 60, 70 years. So they had over 600 people that had changed their legal marker. Based off of how many changed it back, they were 0.47% that had detransitioned. 0.47. And the UK, yeah. The UK did a similar study that was 1.47. So yes, somebody who in some lived experience, whether that was full social transition, they considered themselves transgender for a period of their life. It did not specify these studies like whether or not they took hormones or not. It is like lived experience of being transgender and at some point decided to return to their natal gender. That is what definition of detransition for this purposes. So the absolute, I mean, if you're going to go by like numbers, 8% is technically, but like I said, there's a lot of qualifiers in that. So I always say it's somewhere between 0.47 and 2%.
That's lower than people who like regret their knee surgeries, Botox,
oh, all of it.
If you look at the
My other favorite statistic, are you guys ready for this one? There are more surgeries on minors for breast augmentation and gynecomastia, which is getting rid of man boobs, every single year in the United States than there are gender-affirming surgeries for transgender kids. Yep. Yep. And yeah, they don't even need both parents. Like they can do it with one parent, bring it in. So yeah, no one up in arms about those, but it is crazy to me. That one particularly is crazy to me, that no one is like going after the exact same surgeries, just in the opposite.
Eyelid changes and nose surgery.
I mean, most of the people that are most against it have had gender-affirming surgery. Elon Musk has hair plugs. That's gender-affirming surgery. And so yeah, that one's kind of crazy too. So detransition rate it's very low. And once again, in the presentation I give, I do have a slide on this where I have like the myths that we myth bust on it. And one of them is like, but what if they regret it? And then I have all these pictures of me and some of my friends from high school in like the craziest outfits and stuff, where I'm just like, who hasn't done something they regret? Let's start with that. But then the thought experiment I give is like to think back to when you were 16. Like I can remember that. I can remember getting ready for homecoming. I can remember like that feeling. And then I say, now you wake up the day of homecoming and your genitals are the opposite. Is there any doubt in your mind you don't want that gone? Like the first, you're like, the doctor has to see me now. Like it has to be today. And if you were to go to that doctor and be like, this will affect the rest of my young adulthood, you have to do something about it. And they were like, no. Like for me, it would be like, you now have a penis and enjoy dating and enjoy going. Like it would affect every aspect of my life, and there would have been no doubt that I knew that at that time. Like I would not have changed my mind until I turned 18. Like I still would want that. And so I think that mind experiment of just being like you would have known at that age too. Like there is like, it seems like a big deal, but if you had woken up with the opposite, you would want the exact same care.
I just want to make a comment quick. My oldest is a pastor at an affirming church. And when he was younger, and we were talking to some people about LGBTQ rights, he said, the only thing I know is that I am heterosexual. I am attracted to women. I have no choice in that. There is nothing that could make me be attracted to men. And so my assumption is that somebody who is LGBTQ does not have a choice. It is what it is, and they can't change it. Because then, if they could change it, so could I. And I think that's something that, that's not going to change. It just isn't.
That's a good point. They have actually studied social contagion. So this is another one I get a lot. Like, is it just cool now? And it's now that it's in the media. A couple of different thoughts on that. like transgender people have been around since Greece. Like we have it in like ancient literature. One of my favorite terms is two-spirited. So this is like the indigenous tribes like have always respected the transgender community, and they call them two-spirited. That's what it is in their culture. And so that's been around, like I said, for hundreds of years, millennia. And so it's always been there. And yes, like now that we have science and medical treatments and we have awareness of it, yes, those people are going to feel more comfortable coming forward or even knowing what it is. I would say half the kids that I talked to just didn't know what it was until someone gave it a name, you know, and then all of a sudden at 10, they're like, oh, that's what I am. Like because it is a hard conceptual thing. Like they would have known early, you know, they wanted to wear the dresses or play the, you know, G.I. Joes. Like they knew, but they didn't understand and have a name for it until like someone brought it to them. And so that's something that's going to lead to higher incidence, right? Is like just having a name for it and having more awareness of it. But they did study social contagion. So they basically, as much as they could, looked at like how social influences will have kids choosing one particular clique or group or things in the other, and found that it wasn't a factor. So, and I have that study like listed if somebody wants it. The other, like the jokey way I talk about this with families is I'm like, if you're going to choose a group to like try to belong to, you're not going to choose the one that your chance of murder is like 10 times more. Your chance of abuse in schools, and I'm talking physical abuse, over 1/4 of transgender kids have been physically punched or kicked or physically abused. 1/4 of them drop out of school because of the abuse they have. 85% have verbal abuse on a regular basis. No one's going to choose that. No one's going to be like, that's the easy one to go with. I looked at sports, but I was like, no, this is better. So, you know, it's a hard road to do no matter what, just because of how things have played out in our society. And so I just think it's like a little crazy, the concept that someone would like choose that extremely hard road, especially at a young age like that.
The trans woman of color's life expectancy is 35. It's really, really low.
I think part of the social aspect of that too is, you know, people are saying, you know, well, you never saw transgender people a few years ago. Now they're everywhere. But only 1% of the population.
Mm-hmm.
Yeah, exactly. But you know, they point out that it's only 1% of the population. But you think if you go to say like Walmart or something, say there's 300 people in the store, you're going to run into statistically 3 transgender people as you're shopping, and you're going to look and say, yeah, they're everywhere. There's one there. I just saw one back in this department, and the other are all employees.
Yeah. Well, and because of these safety issues, many of them are not like what you like. They do not wear it on the outside. And I say that doesn't mean that's not what you are on the inside. It's the same thing for homosexuality. You know, it's not that there's more homosexuals now. It's that people don't want to kill you for being homosexual as much anymore. And so, you know, that used to be something that even just 30 years ago, you could not let employers know. You could not be out because of your safety. And so it's just safer. So people that always were are just being a little more open about it, I think. Mm-hmm.
Yeah.
Has the depression and anxiety increased over the last 20 years? Is there, because I have a friend that's like, well, we have all this, like, we're more progressive, it's safer, but yet depression has increased.
For youth or for adults? For youth. So there was a spike over the last couple of years. I'm going to let you all guess what that was from. So we definitely were seeing increases going into the pandemic, and then it just skyrocketed after the pandemic. And there is a lot of reasons for that, like lack of social contact, lack of social skills. So this is one of the things that I really do, like science hasn't quite caught up yet with like giving me good data to give you on it, but just in the practice, and I do a lot of mental health, I would say 50% of my practice is mental health. And so I think one of the bigger issues is like with social media and with isolation that is happening with that. And so, you know, there is a certain percent of kids that never went back to school after the pandemic, not small, like 10% that just never went back to school. And you can book learn at home, but you cannot socially learn at home. You cannot have the social dynamics that give us the skills we need to be successful in relationships, in a society that is social by nature. And so this is where I think like the incel culture has really come from, and like the alpha beta culture. So if you guys don't know what those words are, they're basically like people, for the most part men, sorry, that, are so absorbed into their online community because they do not have the social skills to be successful with women or with even like other men in a social world. And so they isolate to this online community that then gives them validation for that. And it gives them very poor, skewed social skills, which makes them violent, which makes them, and this is unbelievably hard to undo. So like these happen at such a young age, like we learn these social skills at such a young age. And once your brain is done growing, at 18, 20, like that's it. Like it's not very pliant anymore. And so, I think that a part of it is this loneliness epidemic of receding into the like cyber world, of receding away from, person to person interactions, and of, how social media and how perceived lives online have so much affected kids in general. And so I do think that plays a part in it for sure. Like the isolation, the fear, everything that happened with the pandemic played a part in that. But I studies with social media that have been completed and that we actually have data the last couple of years, none are good. Like none are like, oh, it's like not a big deal. All of them are like, this is bad for like mental health. And so I think that will probably continue, where we're really going to have to like look at how we dial that back for our kids.
Reading some of the incel communities, it's fascinating just to see what people think, but it's also horrifically frightening.
It is. It's very scary.
And I can't read very much of it. Yeah, right. And it is shocking.
And that's why I always say, like, I think nobody, at least I think very few people like grow up wanting to be bad people. And I say this, I have a lot of students that every time I will inevitably get a student that's like, I don't know how anyone could hit their kid. And I'm like, you don't have kids. Like, I'm just gonna say, like, I don't condone it, but I understand it. And I say the same thing when they're like, how do you deal with these families that are like not good parents? I'm like, no one wakes up wanting to be that. Like no one wakes up being like, I don't want to be a good parent today, and there's other factors that lead to that. And that's where like, I agree, it's scary, but I try to have empathy for like how we got there and like, how do we stop that from happening? Because like nobody wanted to end up there. And that's where I think, a lot of our interventions for this like mental health crisis in youth, I think are going to have to come at this level of, forcing socialization, decreasing social media exposure. Some of the things like taking the phones out of the school, I think is a great start, like where we're doing that, decreasing the reliance on those devices and things like that. That was like so not what we were talking about, but like a total tangent. So yes, the answer is yes, that they were increasing. There was a huge spike and now it's kind of leveling out, but still increasing. And so I think there's so many other factors, especially when you look at how technology, even with like AI and stuff, how it has changed. We are on a cusp of, like the industrial revolution of our age, where we had none of this, like I remember dial up, like waiting for it to get on. I had none of that. And now it's everything, like, that these whole kids' existence is on it. And I think it's going to take us a really long time to catch up and figure out like how we can mitigate some of these mental health risks. So that is my philosophy on why we're seeing so much more of it. But
I read something about like, if you dropped your tray in the lunchroom, right? Or if you tripped over a log at recess, people would laugh at you, but then it was over. Now if you do that, it's on Facebook and they laugh at you and laugh at you and laugh at you and label you. And it never goes away.
And it's so much easier to be mean online.
Yeah,
like
you're not right
yes.
that person.
I've been a big advocate of like trying to do empathy building discipline rather than exclusionary in the schools, which basically means instead of giving them a detention, make them sit in front of that person and like talk about why that was so painful. Because people, once again, these social skills of like not understanding empathy and not understanding what other people are going through, but we all inherently have that. And so to like try to bring that forward in a place to build empathy rather than like dissuade them from doing it by
for a generation, it's just told by people with a wide reach that empathy is.
It's crazy to me to like hear words out of kids' mouths that I'm like, you didn't know what that meant. Like, I'll give you a really good example. My son's 8, and we obviously don't talk like this in the house. But he was playing with his sisters, and they were chasing each other with like Nerf guns or something. And he picked up a belt, and he said, "Let's go back to the 40s and hit women like we did." And it's not the type of kid he is. Like, I want to be really specific. He's a very caring child. And I just went, whoa, like, where did we hear that? Because that is not something you are inherently going to come up. That knowledge does not exist for you. And so even these like exposures like that of adults that are, using this language. And I that's why I say, like, one of the biggest reasons I went into peds is because the kids never do it to themselves. They don't have a choice. And if they are, raised and ingrained in this culture of hate and of thinking these thoughts, like, it is going to be unbelievably difficult to undo that kind of conditioning. And so I don't even blame them for that, where it's like you didn't choose that, you heard it from somewhere. That's not like an inherent thing you had. And like, we had a long discussion about why it was inappropriate. And of course he did not know, and he's just like, oh, so they taught us and like this. And I was like, well, we need to have a talk. I said the same thing. We need to have a talk about why that's being taught that way.
Well, a lot of the white-centric religions are teaching kids that their bodies are bad, that their bodies can't be trusted, that their bodies are broken. And so that's what you're getting from the womb. Like, no wonder all these kids are anxious and depressed and traumatized.
I think there wasn't even, there's some people don't even have language for it. I think even adults didn't even have a safe space where they could say, hey, I'm struggling with these feelings or whatever. Like, even men have a hard time crying and showing emotions and things. And so if you don't even know what anxiety is, then you put a label on it. Now we have conversations, now we have that teaching in schools and even from peers, if they're not getting it at home, that they now can put words to things. Oh, I guess I'm feeling depressed, or oh, I must have that anxiety. So, well, and I said something to a person the other day of like, years ago, our mental health crisis, we had a thing, I'm old enough to remember what it's called going postal, but it was grown adults that was just snapping. Now we've had it for decades with children in schools. So it's like the mental health issues have always been there. It's just that they're now not just adults, it's more kids are dealing with it.
What other questions? We got like so tangential on like so many. It was good conversations though. It was.
I think so much of that affects those of us that have transgender. So I mean, our younger daughter is transgender and struggles from social anxiety. She was a sophomore junior during COVID, didn't get to develop any of those things, and struggled with it before then, and it just made it worse by a million times. And while they're not necessarily just about a transgender child, I think it definitely affects them as well, and I really appreciate it.
Oh, it is. And yeah, and I always, that's where I say I think like these parent support groups and stuff are so important because, just as a parent of kids who are not neurodivergent, who have we're very fortunate, every, privilege and advantage in the world. Like, I'm still nervous about sending them to school. Like, there was a gun threat just the other day in, one of the neighboring schools. And it makes me nervous about their safety. I can't even imagine knowing the statistics about, LGBTQ kids and trying to feel safe, sending them someplace I'm not there to help protect them.
Both my daughters get personal alarms to carry on because I know that one is not very verbal in the first place. And so the idea that she's going to yell for help if she's attacked while she's walking around Bradley seems super unlikely. I feel like she might at least question but I hope I'm not adding to their anxiety, but at the same time, how do I balance their anxiety and my anxiety and keep them safe and not make it worse?
It is such a hard line to walk, I think, in today's day and age. I think there's a lot of hard lines as parents that we have to walk that just like we don't have any precedent for. So even the cell phone thing, like what age do you give a kid a cell phone? We have no precedent for that. There's like some data coming out now, but if I don't let him have one, then he's not going to have play dates. He's going to be left out of stuff. And if I do, then there's all these negative effects that can happen from that. And it's just, I think there's so many things we don't have good guidance for because of that, industrial curve of everything that's happening. And I agree, like, especially, this is a weird time where like we kind of have to talk about some of these things that are scary, that are, but are very relevant to their lives no matter what. And so I do think, having those conversations at an age appropriate level is good. And I think important. And I think that we're not doing any service to them by hiding them from what is happening in the world. Because that anxiety is going to come at some point. It's either going to be with you walking them through it, or because they hear it from somewhere or see it on the news, and also be like, what? Half the world hates me? It's like, oh, crap. Yeah, we probably should have talked about that earlier. It's a safe place to kind of have those conversations. I do like a lot on my, on my YouTube and stuff too about how I'm navigating this with my own kids, because obviously I do a lot of advocacy. Obviously, when there were safety issues during the board race, we had to have those conversations, and that's why I say you can still have them at age appropriate levels. And kids are not nearly as bothered as you think they are. I say that all the time. It's not a big deal. So, my son was 5 the first time it came up. We were at Red Lobster. We had a non-binary waiter. Of course, 5-year-olds have no filter. So, come up to the table, turns to me and goes, "Is that a boy or a girl?" Just loud as can be. I was like, oh boy. And I was like, buddy, does it really matter? They're just to bring our food, does it matter? And he really thought about it for a second. He was like, nah. And he went back to coloring. And so then I was like, do you want me to teach you how to ask politely? And he's like, no, it doesn't matter. I'm like, went back to coloring. And that's how traumatic it was, and even now I keep the message pretty simple. We go to a lot of, advocacy events. We went to Pride Fest, downtown, all those things. And I just say hey, how mom has friends like this, you have friends like this. We have, same-sex couples that we're friends with, and we have play dates and stuff. I said, not everyone thinks they should be able to do that. And we just want them to know that we love them and that we support them, and that, everyone else is due to this. And that's why we go to these things. And it's that simple message, but what it's going to do is it's going to not other this experience. And so that when they grow up, they will not inherently have a othering of the LGBTQ community. It's just gonna be no, these are just people that, also have these positive celebrations of things. I mean, we went to Irish Fest and I was like, isn't being Irish? That would be so fun. And it's kind of the same idea. And so the same thing when I talk about gender doesn't have to be as hard as everyone makes it out to be. Neither just talking about these things. It's literally that simple. Not everyone thinks they should be able to do this, and they try to make their life really hard. And so we're just here to make them feel like their life doesn't need to be that hard, and they have support. And kids kind of get that.
When kids are 1.5 to 2 years old, that's when all of biases about race, gender, sexuality, abilities start to come into play. And so it's usually often parents who are not teaching their children about how people are able to be different. And that's the fascinating part too, is children are often a lot kinder than we give them credit for.
They don't differentiate until they hear that from their caregiver.
One of my favorite examples where I was I gave myself a pat on the back and I got an extra big ice cream that night. I was like, you're doing a good job as a parent. Is she was, how old was she? She was 4.5, almost 5. But she could not remember the name of one of her friends. And she was just describing to the extreme. She was she has curly hair. She's pretty. She has the sister. She has wears these clothes, all of that. And I finally get to the end. And then I was like, Mackenzie? And she's like, yes. And I was like, never was it my Black friend. It didn't even come up. It was the obvious descriptor. We don't have very many, and, it was the obvious one. But she went to hair and eye color and all these other things. And like I said, I got a big ice cream cone that night. Where I was like, you did a good job, making sure they didn't see that. Because I don't disagree. It does come. And I had this interesting discussion. It's interesting, just people's views on this, because in the high school over in Morton, they use the N-word a lot, in the parking lot and stuff. And so, conversations about, some parents are, I feel like we should have the right to, teach that and things. And I'm kind of yeah, in the home. But part of public school, in my opinion at least, is teaching you how to, survive in the real world. And so, part of that needs to be, you will lose your job and you might get your ass kicked, for saying that. And those are, realities that we should be preparing them for. So fine, be hateful in the home, but, part of, and tell them that you don't agree, fine. But in that environment, I think we really need to be emphasizing how this affects you in the real world. That's part of a public education, is we tell you how to do a resume, and part of it should be don't say the N-word in the interview. That's, I think something that should be taught. But it's interesting to hear different perspectives on that, on what parents think are rights and what are overstepping and things like that.
I was just saying, so it's kind of come up where my child has been called names and stuff like that and everything, and I struggle with how I'm supposed to approach that and deal with it, because my initial reaction is like, tell me who they are, go to the
Oh, yeah,
school.
Mama Bear. I'm the same. Brr, who is it?
It's not okay, you know. But then there's the other part of me that's like, I don't want to create a big problem if it's just kind of like a passive thing. And my child, she says, it's fine. Yeah, it was hurtful, but I got over it. So it's like,
So you're doing the right thing. You follow their lead. So like, because they're going to know better than you. Like they're going to know how that's going to affect them. They're going to know whether it's a positive or a negative. So like, I definitely have some patients that do not use the bathroom of their choice. And like, obviously it would make them feel better. But when we talk about like that they have a legal right to that, if that's what they want to do, like they're like, it's just not worth it. Like my mental health benefit would be not worth the other issues that would come from it. And so like, I don't want to make that battle right now. And that's fine. It's their life. It's their choice. And so I say like the option's there if you want it. And so you can like talk about those options. That's okay to be like, hey, like we could do this. We could talk to the principal. We could get people involved and make them do this. If that is something you want to do. And then I just leave it in their hands. I have it pretty good here, you guys. And if you guys want one too, I don't know the status of everyone here, but this handout has tons of really good resources for school stuff. And I'm looking at which one.
well, and we're coming here.
Oh, hey.
Maybe we'll have you.
Yeah, it's either, there's only two choices, so me or the other one. But they have a good guide for the schools. It's like 50 pages long. And I usually print it off for parents and tell them to like give it to them. And at the end is a gender plan. And so it kind of like looks at everything like that you may not have thought of. And that's why I like it, is it has like a checklist of the things that someone might want or might not want. And you can just kind of put either your preference on there and you can go over that with her. And you can be like, is this something you'd want? Like, and the nice thing is it goes in the same category as like a 504 and IEP. So like everyone can see it so that she doesn't have to explain it 20 times. They can just be like, this is her gender plan. Like, this is what we would prefer you did. And it's like puts it in one place. Yeah, and that's why I say I have both types. I do. I have some that are like, screw them. Like I don't like. I know me. I don't need their affirmation. And I have others that want to do things that are really gung ho about their own advocacy and being involved and being loud and vocal. And I have some that really just want to survive. That just want to like fade into the background and have as few problems as possible. And I think just letting them kind of lead that charge, because I agree, Mama Bear is hard to put down. like I've been there where it's like, wow, this isn't your battle. And I get it. But at the same time, we don't live in that environment and they do. And so, they're going to be best equipped to tell you what's a good thing to do and what's not a good thing to do. Yeah. Mm-hmm.